professionals in the criminal justice and treatment agencies meet to bridge the gap on providing trauma care in Suffolk County. And Susan Foster from Casa Columbia discusses her research on the topic of addiction medicine.
Only about 1 in 10 people with addiction just involving alcohol and other drugs gets any form of treatment. That doesn't even include treatment for nicotine addiction. We don't as a country even know how many people get treatment for that.
And we revisit the segment on prescription medicine leading to addiction. Hello, I'm Art Flescher from Suffolk County Health Department's Division of Community Mental Hygiene. I'm your host for Something of Substance, our monthly video magazine. Welcome back. Each month we show how substance abuse, mental illness, and developmental delays affect you, your kids, and your community. We'll also give you a few examples of how services in Suffolk County help people find the inner resources they need to tackle their problems.
Where's Mom? Did she forget me? I wonder what happened to her. What if I get left here?
Drugs and alcohol may make you forget your problems for a moment, but that's not all you forget.
My mother worked hard to be in recovery, and I love her for that.
County was one of the first communities to institute a social host law in response to parties where alcohol was being served to underage drinkers. The law provides penalties for providing a minor with alcohol, even your own child in your own home. We spoke to some experts.
Bridging the Gap began about 12 years ago when we wanted to bring the criminal justice population, the substance abuse population, and provide all the services that were available in our county to work together.
Trauma and addiction, as I've learned over the years, is a very strong indicator on how people respond to treatment. So learning more about trauma and how we can work with people who have had severe trauma, it was very helpful and made me very cognizant of how I should work with people in the future.
I've been to Bridge the Gap before, and I've always found it a positive, enlightening, great experience. You have the opportunity to meet people, network with former and current colleagues.
The beauty of Bridging the Gap is that we get to network. We all get to talk in a room together.
Bridging the Gap is a very important annual conference that we all look forward to, those of us in the field of addictions treatment. And we have relevant topics that help us do our job better.
Every year we try to pick a different topic that we believe is pertinent to the population and what's happening in the county and in the state. And this year we're hearing more and more about our veterans returning from all of our wars, and we also have a lot of people suffering from trauma. So our purpose this year was to provide training to the criminal justice and the substance abusing population on how to deal with the clients who are suffering from trauma.
They do a great job coming up with the new and innovative treatment topics that are always useful in practice with people in addiction. So I can't think of one in particular. Every year it's just something new, innovative, and exciting.
One of the most unique things about Bridging the Gap is that it takes the clinical part of it and then the law enforcement as far as probation, the court system, and brings them together as a team to work on helping the client recover, whether it's psychological or drugs, and they work very importantly as a team.
So I'm here at Bridging the Gap today to present on the Phoenix House Military Initiative. It's our program that we started for treating anyone who's ever served in the military.
I'm interested in the military and post-traumatic stress, and I want to learn more about it.
What we're going to do is show a little bit about what makes PTSD unique in the military population.
I'm here at Bridging the Gap today to present the suicide prevention program from the Northport VA Medical Center, which is similar to what you'll find at any VA medical center throughout the country. and it's been in existence since 2007. Each medical center has a suicide prevention coordinator, and I'm going to be talking a little bit about the components of the program, what it is that I do, and how the VA is trying to keep veterans safe.
Bridging the gap, I feel, is important because we have so many different psychological problems in our society that in going to these conferences, we learn more about these different aspects of what is happening to people.
So I was invited here to the conference today to talk about issues related to forensic psychology. This is a conference that has been going on for a number of years where the interface between the criminal justice system and the mental health field. So I was asked to add my understanding of certain research that I conduct.
Today I'll be presenting information on the history of energy psychology techniques and where energy medicine comes from. I'll also be doing an overview of some of the research in the field, and I'm going to demonstrate with the group on how to use the techniques and how to find the meridian points on their body.
Well, I was asked to speak at the conference today because I am not only specializing in pain medicine, but I've been treating recovering alcoholics and addicts in pain for going on 12 years now. And I have come to get involved in the community effort to help stop the diversion problem that we have. Right now, one person dies every 19 minutes in the United States from a prescription drug overdose. That's prescription drugs, okay? More people died last year from prescription drug overdoses than from heroin and cocaine combined.
In my field, I'm seeing a lot of young, chemically addicted youth, and Dr. Jan's seminar helped me to understand how I could work with them better and how I can direct them to the resources in the community that can help them with their addiction and or pain management.
We're in the midst of an epidemic, and 90% of the doctors prescribing who are prescribing loosely, so to speak, are doing it not with bad intent, but doing it because they're trying to help and they don't understand the consequences of how they're prescribing. And many of them, the vast majority of them, when we do educate them, they are very amenable to treating recovering alcoholics and addicts, to prescribing appropriately to those who are not addicted, and understanding that anybody who's on these medications is at high risk for addiction.
He presented pain management from a very new and unique perspective. He explained to me how he is able to detoxify people that are struggling with addiction and manage pain management at the same time.
Now what I'm doing here is I like to educate, I also like to work with the recovery community, the people who treat recovering alcoholics and addicts, and bridge the gap, which is exactly what we're doing here, between not just criminal justice and the treatment community, but also the medical community. The same exact talk I'm giving here, I give to colleagues in pain medicine.
What I got out of today is that most of the things that I'm doing with my clients is being reinforced of what they were saying today, as far as you have to be with them where they're at.
Making a connection, making a human connection with a client to totally respect their perhaps the most private, guarded trauma that has happened to them, to help them process it so it doesn't continue to affect their lives in a negative way.
There's a spiritual element in the counseling, there's a trust element in the counseling, and you have to be sympathetic and realize where they are at that time.
I have an ongoing sensitivity to people who are traumatized, who are addicted, chemically addicted, and I think that it helps to reinforce the work that I've already been doing, treating the person as a whole, treating the person as an individual with respect and kindness and understanding. So I think it just helps incorporate all of the skills that I've learned over the years and increase my practice with clients.
The Bridging Gap 12, I think, was very successful this year. It's the first time we're in a hotel. I think people came out excited, energized. They learned a lot of techniques and how to work with their clients who are suffering from trauma. And hopefully they will bring that to all our residents of Suffolk County so that we can all be a lot healthier in the future.
We'd like to thank the Suffolk County Criminal Justice and Addiction Work Group for their collaborative efforts to improve the systems that provide care to those suffering from trauma. Up next, we have an informative discussion with Susan Foster from Casa Columbia. We'll be right back. Susan Foster is the Vice President and Director of Policy, Research, and Analysis at the National Center on Addiction and Substance Abuse at Columbia University. She is nationally known for her analysis on the impact and costs of substance abuse in America. Ms. Foster, can you share with us the findings of your research in regard to the gap between science and practice as it pertains to addiction medicine?
In this summer, Casa Columbia released a 5-year study looking at addiction medicine. The title was Addiction Medicine, Closing the Gap Between Science and Practice. The purpose of this study was to understand what we know about the science of addiction, and then to look at what the relationship is between that and what we're actually doing to prevent and treat it. So we looked at the science, we did surveys, we did an analysis of many national data sets, and we also talked to a lot of people who are engaged in this work. And so what we did was to come up with a pretty encyclopedic look at the landscape of addiction science and the workforce available to prevent and treat it, the disconnects, and came up with a set of recommendations about what we need to do to close this gap between science and practice.
What would be your recommendation for physicians to improve their level of care?
Physicians have largely been asleep at the switch when it comes to addiction. There is a huge need for physicians to educate themselves about the nature of addiction, how to screen for it, how to intervene, how to treat it, how to manage the disease, and how to refer for specialty care as they do for any other health condition.
What can family members and other concerned parties do to better assist their loved ones struggling with addiction?
Casa Columbia has done a lot of research looking at the role of families in this disease. Parents, for example, are the most significant influence when a child is growing up, and whether or not they will turn to the use of these substances. The fact is that most parents or members of the community at large are not well educated about the nature of addiction and the dangers of risky use and the importance of keeping their kids from engaging with these substances while the brain is still developing. So the first thing for parents to do and family members is to just get better educated. It's hard, but they need to, and they need to be aggressive when they go into their healthcare providers to make sure that the healthcare provider is screening for these problems and has some effective knowledge of what to do if it should occur.
How can families best evaluate physicians' care over patients suffering from addiction?
There is a huge challenge to parents today who are trying to make sure they get effective care as it relates to both prevention or treatment. They have no assurance when they walk into a doctor's office that their doctor knows anything about this problem. So we have to look at this from two sides. One is to find ways to quickly improve the education, training, and continuing education for physicians across the board about addiction, risky use, and what to do about it. But also, we need to inform parents that this is a public health problem and a medical problem, and that they need to require their doctors to get information for them. One of the things we're trying to do at Casa Columbia is to develop a patient guide. So we would give parents information about what questions to ask their doctors, what they should look for if they're needing treatment, what's the difference between risky use or addiction. Just basic information that will help them navigate the health system when it comes to these issues.
Ms. Foster, your research study concluded that only 1 out of 10 persons dealing with addiction receive help. Could you elaborate on that finding?
Only about 1 in 10 people with addiction just involving alcohol and other drugs gets any form of treatment. That doesn't even include treatment for nicotine addiction. We don't as a country even know how many people get treatment for that. But if you think that it's 1 in 10 get treatment for alcohol and other drugs compared to 70 to 80% of people with other conditions like cancer, diabetes, or heart disease actually get some kind of care, that's a dramatic disconnect. And it's a function of several things. One is that addiction historically, for decades, has been marginalized as a social problem rather than treating as a medical condition, even though the AMA in the 50s recognized addiction involving alcohol as a disease. So we know this huge disconnect exists.
What can be done to bring about a national standard for addiction treatment?
Yeah, the tragic reality is that there are no national standards for addiction treatment in this country. What passes for addiction treatment varies by state and by who pays the bill. There are few restrictions on who can hang out a shingle and say, I'm going to provide addiction care. Largely, addiction is disconnected from mainstream medical care, so it's not even acknowledged through many regulators as medical care. So what we have to do is move the way we address this problem into medical practice. We need to license addiction treatment providers as healthcare facilities. We need to develop core clinical competencies for providers that are based on scientific evidence. And we have to assure accreditation of facilities and programs as healthcare providers and as providing effective evidence-based care.
Can you explain how treating addiction will help improve healthcare costs?
Right now, we as a society are paying at the back end because of our failure to prevent and treat addiction. We're paying, of every dollar federal and state governments spend on this program, if you just look at government spending, it's about $467 billion every year. Of every dollar federal and state governments spend, only 2 cents goes to prevention and treatment, and 96 cents goes to clean up after the problem. With effective investments in prevention and treatment, we know we can change that equation. We can reduce those back-end consequences. And every study we've looked at showed that evidence-based therapies are cost-effective. They do give a return greater than the investment, even though that's not a criteria for any other health condition we're treating in this country. We know for addiction that it is cost-effective to provide care.
Ms. Foster, please give us a sense of why you think prevention is important.
The best way to approach the problem of risky use and addiction is clearly just to prevent it. If we can prevent the disease from occurring, we reduce this incalculable human suffering and huge taxpayer bill at the back end. But to prevent it, we have to understand the disease. We have to understand that there's a difference between the disease of addiction and risky use of substances that doesn't meet medical criteria. Not everybody who's a risky user is going to become addicted, but there's still going to be a lot of health and social consequences that accrue. The most important thing we can do is to understand that in most cases addiction is a developmental disorder. It starts with substance use in childhood and the teen years when the brain is still developing and more sensitive to the negative impact of these substances. So it's very, very important to delay or prevent use of these substances as long as possible.
We'd like to thank Ms. Foster for her valuable research and recommendations for improving the systems of care that involve addiction medicine. For more information about Ms. Foster's research, please visit the Casa Columbia website at www.casacolumbia.org. Up next, we revisit the archive segment on prescription medicine leading to addiction. Stay tuned.
They'll be fine, I hope.
What if you could prevent a young person from getting hurt or killed?
What should I do?
If you could turn back the clock and stop an underage drinking party from ever happening. Now you can. Pick up the phone and call 1-866-UNDER-21. It's your community, your call, and it's completely anonymous.
The issue of opiate abuse has been an ongoing topic of concern in our homes, schools, and communities. What is the correlation between prescription misuse and narcotic addiction? We met with a few professionals to get insight on this dangerous phenomenon.
Prescription drug use began to go up in the early 1990s, reached current levels by the early part of the 21st century, and continues at those high levels today. So where the correlation comes into play is individuals who begin their use of narcotics through prescription use, which is far more common than heroin use.
Prescription drug overdoses are outstripping automobile accidents as a cause of death. So we have a huge problem out there. It's primarily led by the opioid prescription drugs, but we also have a lot of concern about some of the benzodiazepines and some concern about the stimulants as well.
People are becoming addicted to prescription pain relievers. Then they don't have a doctor to prescribe them for them anymore, or they run out of them.
As people that become addicted to prescription drugs are unable to find them or afford them because the prescribing measures have changed, we're putting in safeguards to prevent people from getting inappropriate prescriptions, the price goes up on the street, then people transition over to heroin.
It's a lot cheaper to find heroin on Long Island than it is to buy these prescription drugs from somebody trying to sell them on the street.
Well, the major problem is twofold. Number one, we do not train physicians well in the etiology of pain and in the management of pain, the appropriate chronic management of pain. As a result, there is an overprescribing of narcotic pain medications.
Doctors often find themselves with the dilemma of addressing a patient who's in their office who has complaints that appear legitimate and genuine, and they're trained to respond to people's reports and to do something to treat, if they can't solve their problem for them, they help alleviate their suffering. So they're doing many things out of compassion.
At the same time, we recognize that pain is a very real problem and it has to be addressed. So I think that goes back to our training as physicians.
Physicians have been well trained to respond to pain as a symptom and recognize that treating pain effectively helps people who have acute problems recover more quickly and people with chronic problems remain more functional and have better life satisfaction. Unfortunately, I think what has not gone along with that is doctors have not been trained to recognize substance misuse and addiction and have no idea how to manage those types of situations. So there's an overemphasis with a good benefit for treating pain, there's an underemphasis on recognizing that along with the benefits of pain medication, there are significant costs involved.
So as we put down the safeguards to prevent prescription opioids from being misprescribed or taken inappropriately, we really need to put down treatment as well. We need to have more treatment available.
Now, folks in the treatment community have known about this problem for a long time. In fact, it was good evidence that beginning in the early 1990s and reaching current levels by around 2002, prescription narcotic use had gone up enormously in this country.
In addition to that, the disease of addiction has both a genetic and an environmental component. And when the environment is inviting, such as what happens with the medicine chest, you expect to see an increase, and that's what we're seeing.
The federal government does surveys, national household surveys of drug use, and what they found is that the majority of people reporting misuse of prescription medications actually obtain those medications from their own medicine cabinet or the medicine cabinet of a friend of the family member. So an important step to reducing the availability of these drugs would be for people to appropriately dispose of unused prescriptions as quickly as possible. The Suffolk County Police Department has recently begun a program where they will collect unused prescriptions, no questions asked, at the local precinct station.
I don't think there are very many Americans who throw away the extra pill that they may have left over from a prescription, even if it's an antibiotic. I mean, we just, as a class of people, just don't want to waste anything. So if you open up anybody's medicine chest, my own included, you'll find that there are prescriptions that are no longer necessary for you to have there. And in fact, we do have a program out here in Long Island of give-backs where the police stations will actually take the medications, no questions asked, and throw them into a bin, and then, through the proper channels, they get destroyed.
Nationally, we have been seeing a continued increase of people being admitted to treatment for opiate misuse. There has been about a 345% increase, I believe, over the last decade or so. We're seeing it among youth here in Long Island and nationally.
Federal studies indicate roughly 14 out of every 100 graduating high school seniors has tried a prescription narcotic before they graduate high school. So that makes it fairly common. Much lower levels have tried heroin, but somebody who begins to use prescription drugs and it becomes a problem for them may find themselves turning to heroin as a readily available and initially less expensive, because it's a more potent drug, solution to their problem than continuing to find prescription narcotics. But eventually, use of heroin has its own unique set of circumstances that make it more difficult.
Now, heroin is very hard to control because you have no idea what you're getting on the street. You have no idea what it might be cut with. The levels may vary a lot, and it gets into a whole nother level of contact with other sorts of people on the street.
So heroin becomes a bigger problem. Not only that, heroin isn't government regulated. You don't know exactly what the dosage you're going to administer to yourself is, so it becomes a big problem with overdosing.
Parents are the anti-drug. I agree with that commercial 100%. There's no question that the forebrain, a part of the brain in youngsters, is not well developed, and it's one of the areas where exposure to drugs will actually change the structure of the forebrain and make them more prone to addiction.
The greatest tool for prevention purposes is to, and it's a cliche almost, is to have an open and honest relationship with your children.
Overall, I think that teenagers, young teenagers, older ones, need really straight information about what's going on.
Parents who are on guard about that discuss it with their children legitimately and logically, not from a fear standpoint. But I think that kind of open dialogue is what we need more of in order to prevent some of the addiction we see.
So I think telling the truth is really the most important part of it.
For information about Operation Medicine Cabinet, contact the Suffolk County Community Response Bureau at area code 631-852-6109. For treatment or other questions, please call us at area code 631-853-8500. I'm your host, Art Flescher. Join us again next month for more of Something of Substance.